Are you struggling with breathing? Have you had any diagnosis of a chronic respiratory disease like COPD, asthma, or interstitial lung disease? Or are you feeling that embarrassment, guilt, or shame while you're coughing up that phlegm or bringing around your oxygen cans in the park or in public places? Or are you limiting yourself due to the embarrassment and falling in the trap of depression or anxiety or panic attacks? Or are you having a friend or a relative having all those symptoms? Or are you a healthcare professional having expertise in pulmonary rehab or otherwise known as respiratory rehab? Then this video is for you to look into what we do for support and care for the mental health issues in people with chronic respiratory disease. Hey folks, welcome to Lung Mind channel. If you're watching me for the first time, I'm Ms. Devi Sundar, specialized in pulmonary rehabilitation, counseling, psychotherapy, and health coaching. I have over 20 years of therapy experience in dealing with people with chronic respiratory disease, majorly COPD, asthma, and interstitial lung disease. And today I'm going to talk about, did we understand mental health in chronic respiratory disease right? So under this topic, I'm going to touch on what is mental health, mental injuries, how do we know if your family member or friend or a patient struggling emotionally? What is the management plan to heal mental injuries in people with chronic respiratory disease? And how do you show your care to a person suffering with chronic respiratory disease? Please do watch this video until the end so that you get to know the answers for those questions, and I will see you inside the video. Mental health is defined as absence of mental illness. A person is confirmed to have a poor or a good mental health by their behaviors. But we all forget to label the mental injuries. This not only include PTSD, post-traumatic stress disorder, it also includes the anxiety and depression. There is evidence that people with COPD have higher levels of mental injuries, anxiety, and depression compared to other chronic health conditions. In 2010, a longitudinal study by Schneider et al., looking at 35,000 patients with COPD over a 10-year period, confirmed 16.2 cases of depression per 1,000 person years in COPD, compared to 9.4 cases only in non-COPD group. Why this difference? The impact of mental injury is caused by the lung function impairment, disease severity, and healthcare utilization in patients with COPD, or for that case, any patients with chronic respiratory disease. We all know mental injury reduces a person's quality of life and days of predicted living. How can we know and help those people suffering with mental injuries, especially in people with chronic respiratory disease? How do you know if your family member or friend or your patient struggling emotionally? First thing, you will notice a change in their behavior. What am I talking? You'll see a change in their behavior of their self-care. Examples, stopping medications or medication regimen, inconsistency, lack of sleep, weight gain or loss, complaints of tiredness, fatigue, which is often missed in the assessment, lack of interest in their self-image, feeling very worthless, hopeless, social withdrawal, negative thinking about the future, impaired concentration, hypersensitive bodily sensations. What is the management plan to heal mental injuries in people with chronic respiratory disease? If a person is identified with anxiety, depression, what they do? They reach out to the GP and take a consultation for 10 to 15 minutes and end up with a prescription for an SSRI, metazidine, or antipsychotics. What all those medications do is to improve temporarily the neurotransmitter chemical substance, high or low, to balance your emotions. But it does not improve your neuroplasticity. And the other small percentage will be referred to some form of therapies like cognitive behavioral therapy, CBT, popularly known as, and exposure therapy, and some other forms of therapies like psychodynamic integrative. But don't they necessarily create a change in behavior very immediately? And even for in a long term, they don't focus on neuroplasticity. What am I talking neuroplasticity? Did you hear this before? Neuroplasticity is the ability of the nervous system to change its activity in response to intrinsic or extrinsic stimuli by reorganizing its structures, functions, or connections. The brain plasticity is the brain self-efficacy. Brain reorganizes itself through axonal sprouting, by which I mean like an undamaged neuron, new nerve endings connect with an undamaged nerve cell, forming a new neural connections. 100 years ago, William James, in his book Principles of Psychology, presented the first theory of neuroplasticity, suggesting that human brain is capable of reorganizing. At that time, it was believed only in younger ages, like the first few years of your life, which is termed to be a very critical period, and the neural connections are formed between the brain cells, and brain cells are very active in forming and more plastic. And with aging, this flexibility or the plasticity is reduced, and the older neural pathway which has been formed previously remains very fixed. But this was actually then later realized wrong. It is not that way. In later part of the 20th century, a wide range of research confirmed that many aspects of the brain remain changeable even into their adulthood. Now, I believe I have given more introduction to neuroplasticity. Now, let me talk about how this is making sense when we are dealing with mental injuries in people with chronic respiratory disease. It is widely acknowledged Polymer Rehabilitation is a gold standard management for people with COPD and other chronic respiratory disease. Polymer Rehabilitation is called to have a biopsychosocial model of care. The irony is, in my experience over 20 years, I've seen about 90% of population are having a firm diagnosis of COPD in their 50s or 60s and refer to a pulmonary rehabilitation program in their 70s or 80s. And looking into the pulmonary rehabilitation assessment and delivery of care, most pulmonary rehabilitation programs assess only their demographic, age and gender, past and present medical history of the patient, severity gradient of the physical illness, disability. But majority of the pulmonary rehabilitation settings or the referral sources don't assess the biological context, that's the genetic vulnerability, neurochemistry, stress reactivity, the psychological context like the learning behaviors, attitudes, beliefs, personalities, emotions of the patient, their perception of their illness, and cognitive distortions, coping skills, past traumas, and the social context like their social support, family background, cultural traditions, and social and economic status and education. And I need to actually acknowledge here, most pulmonary rehabilitation setting, including myself, use some form of emotional impact questionnaires on the people's quality of life. Commonly used are the hospital anxiety and depression questionnaire, generalized anxiety disorder questionnaire, GAD-7, and the patient health questionnaire 9, PHQ-9, and geriatric depression scale. But after assessing their psychological impact and reduced quality of life, do we have the resources to support the mental injuries to heal and also to support the contributing social factors? If you could honestly answer, the answer would be no. We don't have sufficient resources to support the mental injuries in people with chronic respiratory disease in the current healthcare setting. How to show the care to a person suffering from chronic respiratory disease, especially to focus on the healing of their mental injuries. 3 tips. Great care begins with an open question. Always apply a compassionate communication to your loved one suffering with the chronic respiratory disease or to your patient to create a psychological safety. How do you do this? Respect their privacy. Listen to what matters to them with no judgments and validate their experience in an intent to create the feeling of trust that will build a strong rapport. Trust has 3 ingredients: empathy, logic, and authenticity. Be yourself with non judgmental attitude. The second tip is to include therapy sessions like cognitive behavioral therapy, acceptance and commitment therapy, trauma-focused or integrated therapy sessions, along with the physical activity and education resources in the pulmonary rehabilitation setting. And the third tip is include activities that promote neuroplasticity. I hope this video was informative. If you feel the same, please do click that like button and share with your friends and network. I'll see you in the next video. Until then, signing off, Miss Devi Sundar.